We're going to talk today about the predictive power of the breast cancer index, H/I biomarker, about extended endocrine therapy, and beyond that topic. This is being recorded, so other people are watching, hopefully live from home. And I'm Dr. Robyn Young. I'm a medical oncologist from Fort Worth, Texas, in a private practice group, and my practice is limited to only breast cancer and high-risk patients who are at high risk to develop breast cancer. I'm joined by Dr. Gadi from the University of Illinois in Chicago, and Dr. Ruth O'Regan will be joining us shortly. She's from Rochester. So we're going to talk about the core difference, first of all. Sort of like one of the speakers said this morning, go back to the basics. Even though I'm in private practice, we still have residents who rotate through our clinics with us. And when I pose the question, what's the difference between predictive and prognostic, I get this blank stare. They can't explain this at all. So a prognostic test tells you how is the patient going to do? What's their outcome? What's their prognosis, regardless of what therapy you give the patient? But a predictive test tells you what's the benefit or what's the therapeutic effect of the drug you're trying to give. So we have lots of things that are prognostic, but we don't have very many tests that are actually predictive for benefit. The ones we have, however, are really useful to us in the clinic. So what I thought of as prognostic, tumor size, obviously lymph nodes, grade, age, menopausal status, Ki-67, other assays, those are things that don't predict benefit to extended therapy. So it would be nice to be able to put those prognostic things together with a test that predicts to let me give more personalized care to my patients. So the breast cancer index does exactly that. It's got a predictive component, which is simply H/I. It's a ratio of estrogen-related genes, and that predicts the likelihood of benefit from extended endocrine therapy. And it also has a prognostic component that assesses the individual patient's risk of distant recurrence. And this is late distant recurrence between year 5 and year 10. And so when you put all that together, you're able to have more personalized care for your patient. So the power of prediction is really very clear and very obvious here. This is how the new report is going to look. The current report, if you look at the bottom right-hand side here, just says yes or no. And then there's a number under that that tells you what is the risk of distant recurrence between year 5 and year 10. So if the answer is no benefit, then there's no difference whether they get 5 years or 10 years of therapy. We all know that extended endocrine therapy has the potential to reduce risk of recurrence by about 60%. So the new report will do the math for us. I'm always fine with other people doing math. This tells us, yes, this patient's going to respond to extended endocrine therapy, and we have the ability to change her risk of distant recurrence from 8% all the way down to 2 or 3%. That's a pretty big difference, at least to us, and so that's going to be easier for the patients to understand these things. So BCI is recognized by our national leading guidelines for decision-making in extended endocrine therapy. It was recognized in January of 21 by the NCCN and in April of this year by ASCO. The NCCN clinical practice guidelines for gene expression assays are listed here. Everyone's familiar with the 21 gene assay or the Oncotype, and that's what we use to predict benefit from chemotherapy. And it's also prognostic. We know that the Mammaprint is prognostic, Prosigna and Endopredict are both prognostic, but the BCI here is prognostic and predictive of endocrine benefit from extended therapy. So these are the actual verbiage from the NCCN guidelines and the 3 trials that are listed here. Dr. Gadi will be going over with you soon. But we want to say that the H/I patients did have benefit, a significant improvement in disease-free survival when they get that extra 5 years, but the H/I low patients did not get any benefit. The ASCO guidelines are very, very similar. They state that this can be in women with node-negative tumors or node-positive, up to 3 positive nodes. And it doesn't matter what endocrine therapy you're looking at, whether it's 5 years of tamoxifen, 5 years of an AI, or some sort of switching combination. And the ASCO guidelines actually call out the fact that the Oncotype, the EndoPredict, the Prosigna, Ki-67, IHC4, those don't have insufficient evidence yet to predict benefit from extended endocrine therapy. I'll now turn this over to Dr. Gadi.
So just at a high-level overview, the robustness of this data is pretty impressive. So when we look at the data collectively, there's over 4,500 patients in which this assay has been evaluated. And each of these trials are different. You know, you can see real quickly there that the design of who was incorporated into these studies, very different, very heterogeneous, but it's the consistency of the finding that gives us faith in that this is a real finding. And that you see when you look at the high predictive score, as you go across for all those trials, it's locked in right around a 2/3 relative risk reduction compared to the placebo arms or the control arms in these study. It's that consistency that's really impressive for me. But also on the other end of the spectrum, when you have an H/I low score or no assay, no answer on the assay, you again can see there's no benefit for those groups, and that's a very consistent finding. So today what I'm going to do is really kind of dig down on a handful of these trials so you can see operationally how this data plays out in these studies. First, I'll start with MA17. This really got the ball running. Just to remind everybody, MA17 was a trial that looked at patients who had been on tamoxifen in the adjuvant setting after a small washout period of roughly 3 months, and they were randomized to proceed with an aromatase inhibitor versus placebo for 5 full years. In the parent study, this was a positive trial with a roughly 4 or 5% benefit for that extension of therapy. In the validation study related to the BCI, they were able to capture 250 blocks or so. Again, you can see the randomization schema that was applied to those patients. And for the parent study, like I said, there was a roughly 4.5–5% benefit from extending therapy. And here, even though it's a smaller subgroup of patients with 250 patients, again, a 4.5%, so suggesting that it's representative of the larger trial. However, when you subset the trial according to H/I scores of low versus high, you can see that there was absolutely no benefit for the patients who had H/I low ratios, whereas there was a nearly trebling or quadrupling of the benefit for the patients who had an H/I high score. Put another way, all the patients that were likely to benefit from extension of endocrine therapy had H/I scores that were high. And on the right, you can see that if you do the math, this is a hazard ratio of 0.35, a relative risk reduction of 65%, and a statistically significant p-value. So this got the ball rolling. This is the first, but they didn't rest on their laurels. They wanted to make sure that this was a robust finding in a variety of different settings. So this takes me to TransAtom. So recall, this is a trial with almost 4,000 patients. Patients may have been on tamoxifen and then were randomized to either stopping or extending for another 5 years with more tamoxifen. So this is what I call TAM after TAM. So that was the parent trial. In the sub-study, I'm showing you here the 790 or so patients that had node-positive disease. They actually looked at this in the node-negative setting within this trial as well, but there were so few events in that study from the node-negative group that we really couldn't apply the test to that. So here, for the moment, we're just focused on the node-positive patients. And again, for the parent study, there was roughly about a 4–4.5% improvement for continuing tamoxifen for the full 5 years. And in this sub-study, in the node-positive subset, you again see a roughly 4% improvement for this group of patients, suggesting that this smaller group is representative of what was observed in the larger trial. However, when you subset these patients, again, based on H/I, the H/I low score, there was no benefit. Actually, it tips down. It's in the negative territory. And really, all the benefit observed for these patients was in those patients who had H/I high scores, a really 9.7% improvement there. When they did the math here, you get a relative risk ratio, again, suggesting a 67% improvement, a hazard ratio of 0.33, statistically significant, and importantly, in the H/I low group, no such observation was made, so suggesting that that group really doesn't benefit. And then ideal. This is a little bit more contemporary to how we might manage our patients. I'll just make one caveat about the parent study, which was a 2,000 patient study. Generally speaking, compared to a lot of the studies like NSABP42, this is a higher risk group. Many of the patients had seen chemotherapy, and the investigators at the time of designing this trial felt compelled to offer some amount of extension of therapy. So here you have patients who may have seen tamoxifen, a aromatase inhibitor, or that commonly practiced switch strategy with TAM followed by an AI. After they finished those 5 years, then they were invited to be randomized on this trial. But here, instead of having 0 years, there was a 2.5 year versus a 5 year. So the full duration of therapy is 7.5 versus 10. In the parent study, there was actually no observed benefit for extending in this trial. In the subset of patients here, you see a 4.9% difference, but again, it's not statistically significant. When they subsetted this patient further based on H/I low versus high, the low folks, again, no benefit. And the high group, you see a 9.8% difference between the two. So a doubling, and really all the benefit to be captured in this study was in those patients there. When they calculated the hazard ratio here, it's 0.42, 58% relative risk reduction, a statistically significant p-value, and no observation of that kind in the H/I low group. Because this is a contemporary study, we were really curious what happened to the patients who had any exposure to an AI. So this is a subset of the prior slide with the 800 or so patients that had seen any amount of aromatase inhibitor use. Here you're seeing a nearly 6.1% difference for the 794 patients in this subset. But when you again subset that patient group further into H/I low, no benefit observed, H/I high, a nearly 12% difference between the two arms. Calculating, crunching out the numbers here, the hazard ratio is 0.34, suggesting, and again, a 2/3 relative risk reduction. And in the H/I low group, no benefit was observed again. So very consistent with what was observed in the other studies. And then finally, probably the hardest study to understand, but we'll go through this carefully. NSABP42, this is the parent study, not the subset. Roughly 3,900 patients, done in the United States and Canada, very, very similar to the patients that many of us will take care of. Patients could have been on an aromatase inhibitor for 5 years. Patients could have been on tamoxifen followed by an AI for 5 years. At that point, they were invited to be randomized on this study, 5 years of extension with an AI versus placebo. And for the overall study, for the outcome of disease-free survival, which includes a lot of different outcomes, 3.3% difference, statistically significant. But by being a statistically significant finding, you can then look for other outcomes. And here they looked at distant recurrence specifically, a very modest 1.8% difference there, statistically significant, roughly 28% relative risk reduction. But the way to properly express this is that out of every 50 patients, 1 was benefited for a distant recurrence event. So a few caveats about this study and understanding the translational cohort. There's a couple different phenomena that play out, but one of the most important is that when you looked at the post hoc analysis compared to the ideal trial, which had a higher risk patient population, they had 88% power to really see BCI operationally be successful. Here in this trial, it's only 50%, so it's underpowered. In addition, and this is something we observe in a lot of studies of extension of endocrine therapy, as these cells are being treated in the adjuvant setting, they're essentially being programmed into dormancy and they're just hanging out. And the minute you stopped endocrine therapy, it's not as if all these cancer cells just suddenly wake up and become active. That reprogramming to become productive cancer cells again takes some time. And so as you start these folks on placebo versus continued endocrine therapy, those differences about the effect of starting that endocrine therapy or keeping that endocrine therapy or discontinuing it, they don't play out for several years. We saw that in ADAM, we saw that in, and now we're seeing this in B42 as well. So there's nearly a 4-year time period before the curves actually start to separate. So when you're doing a translational study like this, you have to correct for that. You have to account for that. And so you can see when they do that and they apply that BCI H/I high versus low index, it's really after those 4 years after you've made that correction where you can see a difference, and you can see that in the 2 plots. And this is specifically for distance recurrence. So this is the meaningful endpoint that many of us care about. So put another way, hazard ratio with those corrections made, hazard ratio of 0.29, suggesting a 71% relative risk reduction for the group that it was extended on AI, and no such observation for the HRI low group. I know that is complicated. It's almost unfair because you almost understand something you thought you understood, but it's important to actually go through that very carefully so you know how the test works. And finally, I'm going to move to this next section, just looking at how this affects our treatment recommendations with our patients. So first off, we all do this. We look at those clinical characteristics and we're making immediate judgments about what the risk of a patient is. And one way that we do that is, for example, we might look at a patient and go, oh, you have nodes involved, you're high risk, right? The cancer's smart, it got to a lymph node, you're just, somebody we're worried about. But at a molecular level, when you're starting to look at the gene expression of these cancers, it turns out a quarter of those patients are actually low risk and very unlikely to benefit from extension of endocrine therapy. On the other end of the spectrum, there's lots of patients we look at and go, oh, the nodes aren't involved, it's a small tumor, you're going to do great. But lurking in that patient population at a molecular level is a quarter of patients who really have high-risk disease. So we risk misclassifying patients when we just kind of rely on those typical pathologic factors. So having a tool that analyzes these cancers at a molecular level can have real impact in terms of our treatment decision-making. And so how does this play out in one of these trials? So here's some curves that have been published before in the IDEAL trial. On the left, you're looking at patients who had nodes involved, T2 tumors, yet had low scores on the BCI index. And what you're seeing is there was no difference for extending or having therapy for 7.5 years versus 10 years. The test just did not identify endocrine-sensitive tumors in that regard, despite the fact that these were high-risk clinical patients. On the other hand, on the left, here are some patients with T1 tumors, grade 1, BCI high. So these are patients we might be inclined to say, hey, you're in a good position, you don't need to extend therapy, yet there's nearly a 12% difference in this study for extending for the full 10 years versus 7.5 years of therapy. So these are contrary to our expectations for these patients. And, we all do this. We look at the ER and we're like, oh, you got really great ER expression, you're going to be fine. You got really great PR expression. But if a biomarker really did correlate with success for extension of endocrine therapy, what you would expect is that the stronger the ER expression, the more likely of that benefit, right? And similarly for PR. But when you look at these on these curves, you're looking at the IDEAL trial, so 10 years versus, sorry, not the IDEAL trial, 10 years versus 5 years of study. And what you're seeing is a fixed difference between the two, suggesting that the test, this ER or PR, could not discriminate who is likely to benefit from extension of therapy. On the other hand, when you look at BCI, what you see is as that score continues to go up, as that ratio continues to increase, the gap between the two arms of extending versus not really does get bigger, suggesting that this biomarker can identify those patients as opposed to ER and PR that are likely to benefit from extension of endocrine therapy. So this has now been updated, and it's not shown here, but they looked at AR, ER ratio, a bunch of other factors, Ki-67 grade, et cetera, and none of those other factors are correlated with benefit of extension of endocrine therapy other than the BCI HRI index. People often say, well, I got a 21 gene recurrence score assay, I should be set, right? Like this should be enough. And what we're seeing is that with these other assays, that as the curves are continued to monitor, they continue to get wider and wider, and the predictive power, the tightness of the fit of that estimate is really lost. And you can see that playing out here. On the bottom, you see the recurrence score in the node negative, but also node negative, known to be HER2 negative patient. And really just the confidence intervals around those estimates for distance recurrences cross 1, they're wide, and really can't predict for who's going to be at risk for those late recurrences. However, when you look at BCI, you can see a clear shift into the range past the line of unity, suggesting that this biomarker can discern compared to the 21 gene recurrence assay. So how does this impact our patients? This is actually updated at this meeting, and when we have these results and we talk to our patients, roughly 40% of the time, we're going to now counsel our patients differently than whatever our preconceived notion was. So this is actually slightly higher than that 25% I was just quoting you just a minute ago, and this is again being presented at this meeting. Based on this, it has been included in these guidelines, as Dr. Young just mentioned, and it's the only test that's recognized by both ASCO and NCCN, and likely to be other guidelines around the world soon, that can be pinned to this benefit of identifying patients with hormone receptor positive disease, early stage breast cancer, that are likely to benefit from extension of endocrine therapy.